a 17-year-old African American woman living with the subtype of POTS disorder known as hyperadrenergic POTS MCA. I am a patient of Dr. Blair Grubb, one of the world's foremost authorities regarding syncope and disorders of the autonomic nervous system. To help bring better awareness to the general public, Dr. Grubb has agreed to talk with me about the unknown common subtype of POTS, hyperadrenergic MCA. Dr. Grubb, I greatly appreciate you taking out your time today to talk with me and sharing with the general community and the medical community about your expertise. I would first like to ask you, what are the characteristics of this subtype?
The term POTS, which stands for Postural Tachycardia Syndrome, is a disturbance in normal physiology. It's a kind of an abnormal physiologic state characterized by an inability to properly regulate heart rate and blood pressure. There are many different subtypes. The most common, what is called the neurogenic, or sometimes called the partial dysautonomic form. In those individuals, they tend to have very low blood pressures. They tend to have blood vessels that are too loose most of the time, and their heart rates go up somewhat as a compensation. On the other hand, in the midst of our research into that group, we found a second group where they tended to have similar but somewhat different characteristics. They tended to have oftentimes very high blood pressures, and at the same time they had very high heart rates. This group, which we called the hyperadrenergic form of POTS, was a smaller subgroup and only constituted about 10% of patients. Further investigations into this subgroup revealed that it was not composed of all one type, but rather there were subgroups within a subgroup. And investigators at the Vanderbilt University, under the direction of Dr. Satish Raj, found that a second subtype would occur when people had mast cells. These are cells of the body that respond to inflammation or other kind of stressors, would over-release certain chemicals, and those chemicals would cause an over-relaxation of blood vessels. And the person would become flushed, red, and their blood pressure would drop, and their heart rate would get very, very high as a compensation. Now, I think most people in the field had noted this clinically before, but to his credit, Dr. Raj was the first one to put it all together and publish it. And what he showed is this mast cell instability syndrome was a distinct subtype of hyperadrenergic POTS. And as I mentioned, what it's characterized by are these intermittent episodes where the person becomes extremely flushed, gets red, oftentimes gets urticaria, and their blood pressure gets very low. Their skin gets this real blotchiness to it. One of the difficulties in dealing in diagnosing this in some African American patients is, and then in Caucasian patients, it's much easier to see the redness and blotchiness of the skin than it is in the darker your skin is. It's harder to notice that. And so I think some of the African American patients aren't picked up as quickly just because of that. And when this chemical that's released is one that most people have heard of, it's called histamine. And histamine causes blood vessels to relax and causes fluid to leak out. That's what causes stuffy noses when you have a cold. When people have anaphylactic reactions to drugs, in other words, if they're allergic to penicillin and get penicillin or if they're allergic to peanuts and get exposed to peanuts, what happens is they have a tremendous release of this chemical called histamine, and it can be potentially lethal because it can drop their blood pressure to levels close to zero. When all this histamine is released, as I said, blood vessels relax, their blood pressure drops very quickly, and heart rates go up very high as a way to compensate for it, but frequently it's ineffective. And one of the consequences is their blood pressure will be low enough they will lose consciousness. And sometimes it will be a very profound loss of consciousness with the blood pressure getting extremely low and staying that way for a while.
Well, is there a difference between hyperadrenergic POTS and hyperadrenergic POTS MCA?
It's still a field of investigation. There, in the regular group of hyperadrenergic POTS, the first subgroup that was identified were people that had a genetic disorder where one way to explain this would be to say that their nerves leak adrenaline, and they would leak adrenaline into their systems and out of nerves. It's a genetic disorder, and these individuals' heart rates and blood pressures will get extremely high. We also now realize there's probably a type of hyperadrenergic POTS that occurs as an autoimmune reaction. And this type occurs because the person's body makes antibodies against their own blood vessels and certain receptors within the heart, and allows the heart rate to get all out of normal range in those individuals. So this is still something we're trying to figure out, and it's oftentimes very complex physiology. One of the differences is these are not the most common types of POTS, and so you don't quite see as many people with them. And it's all, I think, for all of us in the research field who have been trying to understand these, it's a little harder to do because you just don't have as many patients.
Okay. Well, what would the key or signature symptom be that would help doctors to think in this direction?
In the patient where their episodes are always preceded by flushing, the medical term for this is called urticaria, this sort of red flushing-like sensation, accompanied by an extremely high heart rate and then sudden loss of consciousness, one should begin to consider the diagnosis in that setting.
Okay. Well, what would be the next step for a patient?
There are research tests to, if you can catch an episode right as it occurs, which is sometimes not common, urinary samples you can show high levels of histamine breakdown products in it. Sometimes you're left with making what's called a clinical diagnosis based on the symptoms and the response of people alone. And at that point, therapeutically, the approach to the hyperadrenergic MCA people is a little different in that you use drugs to block the release of histamine and make the mast cells more stable. And these include not only antihistamine drugs, but also ones that block the histamine receptors, and they're called histamine 1 and 2 receptors, so that drugs that are frequently used to treat acid reflux disorders and things are commonly used as a therapy along with the classical antihistamine agents.
Okay. Well, are there appropriate tests to determine whether a person would be diagnosed with this subtype?
As I mentioned, you can measure urinary histamine levels. You can also sometimes measure mast cell stability, but both of those are still in a research phase and are not commonly available. So oftentimes it is a diagnosis of exclusion by excluding other potential causes, by measuring the catecholamine levels, the adrenaline levels in someone's system, and showing that it's not one of the other forms, and then basing it upon the history and clinical presentation of the person.
Okay. Well, I know personally I have hyperadrenergic POTS MCA. Does this run in the family, having a strong family history?
It is not yet clear. In some of the other forms of POTS, there is certainly a very strong hereditary basis, and it runs within families. I don't think any of us can quite tell for sure yet. We think it might, but I can't give you a definitive answer on that yet.
So approximately how many persons have this subtype?
That is also very unclear. The whole POTS population in the U.S. is probably somewhere between 50,000 and 750,000 patients. 10% of those are hyperadrenergic, and my educated guess is maybe 10% of those have the MCA variant. So it's not a very large group, but I can't give you an exact number yet.
Wow. Well, what would be the recommended medical treatment for patients with this subtype?
One would employ a histamine blocking agent such as Zyrtec or Benadryl or any of those types of things. We tend to use Zyrtec or Claritin because they are not sedating the way Benadryl is. We would then add to it a H2 blocker, and these would include Zantac, Tagamet, Pepcid, and things like that with it. You also frequently will add small doses of aspirin to some patients, and that combination tends to stabilize mast cell function. You try to avoid steroid agents because of the fact that even though they work, there are a lot of side effects, although some people will do that originally.
Okay. Well, considering, Dr. Grubb, that there is only one clinical research paper, and that's done by Vanderbilt University School of Medicine, and that was released in 2004, do you have an interest in further researching this subtype and releasing your findings?
We are presently gathering data on this subtype. I believe we have, I'm going to give you an educated guess and say about 12 patients that we're following with this subtype. Now that's out of Dr. Kerrigan and myself see about 2,000 patients a year. So, and I've been doing this for 20 some years. So out of that entire time we have about 12 or 13 people. So it's not a very large group. So yes, we are actively pursuing investigations in this group, and we'll eventually publish our data, but probably will be a little while yet.
So, what information can be given to school systems when this disorder involves school-age children like myself?
The one is just recognition that it's present. The fact that it can be extremely disruptive to someone's functional ability, and that the child affected may need special educational opportunities and either be homeschooled or have reduced schedules. Be allowed. Some children are able to attend part of the day, other ones are not. There's a high degree of variability, and that the school system has to be aware of their special needs. And the fact that these episodes are very unpredictable, oftentimes are brought about by stress. Stress is everything from both emotional stress to heat, illness, and a number of other things. And so the young person has a chronic ailment that has to be recognized by the school authorities, and accommodations have to be made to allow them to pursue their education like every other child.
Okay, so I know that a lot of people with POTS are bedridden, but I have read that this can in itself can have an adverse effect on their recovery. How important is exercise program?
It's an extremely important thing. As a matter of fact, probably one of the most important things in the majority of POTS patients. One of the ways that you help maintain your blood pressure in most situations is through contraction of the leg and abdominal muscles, and it's a mechanism called the skeletal muscle pump. And it is dependent upon the strength and exercise tone of the muscles. If you stop exercising, you lose that tone extremely quickly, and it makes people feel worse, and then they do less exercise, and then that makes them worse, and it becomes a vicious cycle. So patients have to break that cycle, but it's very hard work to do, like any kind of physical therapy or any kind of reconditioning. It would be the same as if someone hurt their leg or broke a leg or broke a hip and had to learn to walk upon it again. So that the individual has to pursue reconditioning. That has to be a major focus of what they do.
Okay. Well, I know many young people first present with symptoms in their mid-teens with the pressure of exams and also life generally. Once these pressures have subsided, will these symptoms of POTS diminish?
In most patients, they will become more controllable.
Okay. Well, Dr. Grubb, I greatly appreciate you taking out the time today to talk with me and share your expertise and, on this subject.
You're more than welcome.
Thank you.